Welcome to this explainer. If you've ever stood at the bedside totally overwhelmed by a patient's bouncing eyes, well, you're not alone. But today, we're decoding nystagmus and saccadic intrusions, turning all that confusion into a rock-solid diagnostic approach you can actually use.
Imagine your patient tells you the room is bouncing. That's oscillopsia, this disorienting, often nauseating illusion that a perfectly still object is in motion. Our job? Figure out exactly why it's happening, and more importantly, how we can stop it.
I love this perspective from the source text. It says, recognizing and characterizing abnormal eye movements should be an enjoyable exercise, using our knowledge of neuroanatomy and the physical examination to help patients. I mean, how great is that? It reminds us that we don't need million-dollar recording gear. We just need our core clinical skills and a good diagnostic approach.
All right, here's our roadmap for today. 1. Visualizing the problem. 2. The bedside diagnostic approach. 3. Evaluating saccadic intrusions. 4. Decoding nystagmus waveforms. And 5. Red flags and interventions.
Section 1. Visualizing the problem and building that mental map.
So this flowchart gives us our game plan. And the very first fork in the road comes down to one incredibly simple question. Is there a slow phase? Seriously, that single observation dictates your entire diagnostic approach from there on out.
Here's why that slow phase matters so much. On the left, we've got nystagmus. Here, the slow phase is the actual culprit, causing the eye to pathologically drift off target. But on the right, saccadic intrusions. These are driven completely by unwanted fast eye movements that disrupt fixation. No slow drift at all, just fast, jerky jumps.
Moving into Section 2, the bedside diagnostic approach, step by step.
Okay, here is your bedside action plan. Step 1, are the movements binocular or monocular, conjugate or disconjugate? Step 2, if it's a saccadic issue, check for an intersaccadic interval. Step 3, if it's nystagmus, is it jerk or pendular? And step 4, this is arguably the most crucial tip, evaluate the company it keeps, meaning what other neurologic signs are tagging along, because they will almost always hand you the diagnosis on a silver platter.
Section 3. Evaluating saccadic intrusions, where the interval is key.
So, what exactly is the intersaccadic interval? It's just a tiny pause, about 200 milliseconds before the eyes return to visual fixation after a small unwanted saccade. It's literally a fraction of a second, right? But the crazy thing is, the presence or absence of this tiny pause totally alters your diagnostic pathway.
Let's break down why that interval is a total game changer. Take square wave jerks. The interval is present here. These are actually super common, often just benign things that happen with normal aging or maybe linked to cerebellar or basal ganglia diseases like Parkinson's. But contrast that with ocular flutter and opsoclonus. Here, the interval is completely absent, just rapid back-to-back oscillations. And that is a huge red flag for high-stakes stuff, like neuroblastoma in kids or paraneoplastic syndromes in adults. If you don't see that interval, you've got to act fast.
Section 4. Decoding nystagmus waveforms, looking at jerk, pendular, and localizations.
Jumping back to the nystagmus side of our tree, let's look at the physical movements. See the difference? Pendular nystagmus just has these slow, sweeping phases, kind of like a grandfather clock pendulum. But jerk nystagmus is totally different. The eye drifts off target with a slow, pathologic phase, and then bam, it's snapped right back by a fast corrective phase. Nailing down the shape of these waves is foundational to your diagnostic approach.
And the beauty of this is that these waveforms map perfectly onto our neuroanatomy. We're talking about tracing eye movements directly back to highly specific brainstem and cerebellar structures. From the burst neurons in the pons to the neural integrators in the medulla, these waves are basically giving you GPS coordinates for the lesion.
Here is your mental cheat sheet for those coordinates. Notice how chronic downbeat nystagmus points straight to the cerebellar flocculus or paraflocculus. But acute upbeat nystagmus, that screams pathology in the dorsal medulla or pontomesencephalic regions. Or gaze evoked nystagmus, that tells you you're dealing with a leaky neural integrator network. This is the absolute core of a targeted diagnostic approach. You literally let the eye movement tell you where the problem is.
Now we absolutely have to talk about vestibular nystagmus. It is absolutely crucial to distinguish a benign peripheral issue, like BPPV, from central nystagmus. Peripheral is unidirectional, follows Alexander's law, and suppresses if the patient visually fixates on something. Central nystagmus, on the other hand, it can change directions, it can be pure vertical, and it doesn't care if the patient is fixating. It won't suppress.
A central nystagmus can totally mimic peripheral signs, but might actually be a dangerous posterior fossa stroke. That right there is exactly why the HINTS exam is non-negotiable for acute vestibular syndrome. Finally, Section 5, Red Flags and Interventions, knowing when to act fast.
Let's highlight the red flags that demand urgent action. Acute, upbeat nystagmus. Suspect Wernicke encephalopathy and push IV thiamine immediately. Opsoclonus or ocular flutter. Suspect neuroblastoma in kids or paraneoplastic disorders in adults. Horizontal central vestibular nystagmus means you need a HINTS exam to rule out a stroke or demyelination right now. And seesaw nystagmus, start thinking about a large sellar lesion compressing the optic chiasm. Catching something like upbeat nystagmus and giving thiamine can literally save your patient's life.
Which brings us to our core management philosophy. Treat the cause, but manage the oscillopsia. Obviously, treating the underlying tumor, stroke, or deficiency is the top priority, but we can't ignore the patient's lived experience. Debilitating oscillopsia absolutely wrecks their quality of life. The literature points out that meds like dalfampridine for downbeat nystagmus or baclofen for periodic alternating nystagmus can be game changers for symptom relief. We have to treat the whole patient.
So, let me leave you with this. The next time you walk up to a bedside and see the patient's eyes bouncing, are you going to immediately reach for an expensive piece of diagnostic equipment? Or are you going to pause, take a step back, and simply look at the company the eye movement keeps? I hope this explainer gives you the confidence to realize that the most powerful diagnostic tool in the room isn't a machine at all. It's your clinical reasoning and your algorithmic approach. Let the eyes tell you the story, and the diagnosis will follow. Thanks so much for joining me.